We're live here today talking about NCLEX. I am so happy to have you here, and it's been a long time coming. We have talked about me trying to help others. Now, I do know that having passed my NCLEX, I'm doing it full time and being able to navigate those paths. I was like, the best thing I can do is to help others. So I did talk with some people and they were very excited to help me, or they were very excited that I joined in their journey to help them achieve the dream of becoming an RN in Canada and in the US. And this is why this video is being filmed with you in mind. Just a minute, I'm going to be sharing the link for you guys to join, and you can already see what we're going to be talking about. So let's see how many people are there on YouTube. Yeah. So if you're already watching this video, it means that this is the, if you're watching live, welcome. Or if you're watching later after 8 hours, this is the replay, but you can always go through the question. Today we're going to be talking about the very first step of client management, which is all about prioritization, all about infection control, all about safety, delegation, and all that stuff that NCLEX loves to ask to test your knowledge on. And when we talk about prioritization, you can never avoid that. You will always be asked that. So today we're going to go through that, and at the end of the explanation which I'm going to be giving today, we're going to have some questions. So it's going to be more of the next gen format. We're going to be answering some questions. I'm not going to be telling you why the options you thought was the right option may not be the right option, and I'm going to help you think critically, like put on your NCLEX heart and think critically. But I really want to know that others are joining in, so I'm going to see who is here and see if I can just go forward, because I really want at least one person to join so we can do the question and answer. This is not for me. I've already passed the NCLEX, so let's see if others are coming. I'm just gonna leave a chat. If you're here, please say hi. If you are here, please say hi so we can start. I'm just gonna leave a reminder to the group members. Oh, good. I think I have one person and I can start. Perfect. Okay, Uloma, thank you for joining. I think we're ready to start. Just leave hi if you can hear me so we can start. Leave a hi or leave a comment. Tell me I can hear you. Let's start. Because I really can't see my screen. We're ready to start. Just perfect. Okay, let's start. As always, I will always think about God because He's the giver of life, and without Him, we can do nothing. So, we're going to pray and start. Heavenly Father, we just want to thank you for being a sovereign King. Thank you for this opportunity and this platform you've given to us to help ourselves. We invite you to please take charge. That you prepare our hearts to learn. You said, in accordance to your word, that he who lacks wisdom should ask from you. So, God, we come boldly asking that you please look upon us with mercy and give us the wisdom that as we study for those that are preparing and hoping to pass the NCLEX, that they will come back rejoicing. Take absolute control, for we pray with thanksgiving in Jesus' name. Amen. So on the WhatsApp group, I have shared that there are some lab values you need to know as one preparing to take the NCLEX, and I have added that on the WhatsApp group. If you're not part of the NCLEX review group that I have created and you want to join, you can use the email roselomon.business, send a message, and I can add you to the group. Please, every day go through this documents, try to know them, the white blood cell, what is the normal range, because even with the next gen, although NCLEX may give you the value, but sometimes they may not give you the value. So it is important that you actually go through, know it by heart, and it's going to help you as an RN. So the red blood cell, the hemoglobin, hematocrit, and all that. Now, when we go through the questions, you will understand why I'm like, you need to know your values, you need to know the range. That being said, let's go straight to today's class. Uloma, at any time, if you cannot hear me, please let me know, so I know that I'm not just talking to myself, because I will want us to. And if you're joining here, I can see that Uloma is here, but if there's any other person that is joining, please say hi so I know that you're there and you can hear me. Okay. Today we're going to start with, or we're going to be talking about the nursing fundamentals. We're going to be talking about safety. We're going to be talking about infection control, prioritization, and delegation. Now, while I was preparing these notes to talk about this NCLEX or to teach you about it, I decided to go through the NCBN, so the nursing board that does the question and answer and the preparation, and of course the grade students and ultimately give you the license. They had written the test plan. Now, this is the exact test plan I used in 2023. I wrote my NCLEX for the first time, and to the glory of God, I passed. So whatever we're talking about is the same strategy, the same question bank that you also be tested on, especially if you're going to be writing your NCLEX this year, 2025 and 2026. Now, as I said, I went through the NCSBN, and we're going to be talking about one section, which is the safety and infection control. And it comprises about 8 to 14% of the nclex-rn test plan. So tell me if you can hear me, Uloma. Let me see before we start with the standard precautions? I can hear you perfectly. Good. Now, when you see the NCLEX question, you will always see something like, what do you do in this case? It is just to assess when it comes to infection and safety. It is just to test your knowledge. If you know that there are no-brainer procedures you need to know as a nurse. Now, that is why they are called standard precautions. So, be you a patient with, or if you're taking care of a patient with tuberculosis, or you're taking care of a patient with, let's say, flu or wound care and stuff like that, there are standard precautions you need to know. So I highlighted it. If you don't remember anything, remember standard includes everyone. There is no demarcation. It's not like, oh, you're black, you're white. No, everybody falls under this. And as a nurse, the least you can do in NCLEX situation and of course in real life is the standard precaution. Now, what do they comprise of? Hand hygiene. Before you do any procedure, be it blood transfusion, giving injection, you need to clean your hands. And this cleaning of hands can be with soap and water and all the disinfectants. Depending, if you're going to be touching bodily fluids, by all means, if the NCLEX is asking you, the base, what you need to think of is, am I in contact with any bodily fluids? Am I in contact with some kind of wet surface? So if there's a wet surface, bodily fluid, you use the soap and water. But if it is a dry surface, you can always go with hand disinfectant. But in an NCLEX situation, if they are asking you to choose between disinfectants and soap and water, by all means, go for the soap and water. Now, the other standard precaution we need to know is the gloves. And this is usually, not all the time, usually when you are in contact with blood, bodily fluids, skin that is open. So like the burns, when someone has this water or chemical fall gets on the skin and the body is exposed, you need to cover your hand with gloves so you're not transmitting infection. And of course, mucous membrane. And we also talk about the personal protective equipment. This is based on exposure. Now, what kind of clients are you dealing with? Then you need that. But I think after this, we're going to be talking about the kind of the personal protective equipment you need to wear. When we had the COVID endemic or epidemic all over, there was the need for us to put on the gloves, put on the gown and all of that. But if it comes to flu, you don't really need to put on the gown, even if you may need to put on the face mask. Okay, now another part of the standard precaution is the needles. You should never, in an NCLEX situation, when they test you, if you see the needle thing, if they're trying to test you on safety, they're trying to know if this nurse knows how to protect herself, and ultimately they are trying to ask, does she know how to protect her clients? So if you cannot protect yourself by not recapping the needle, it means that you're a threat to your patient and you're a threat to the nursing profession as a whole. So if you ever see a question in NCLEX trying to ask you what did the nurse do well or did not do well, and there is something about recap a needle, never choose that. NCLEX doesn't want you to recap a needle. Even if there is a safety cap, don't do it. Don't ever choose that answer. Okay, now patient equipment. Sometimes there will be a need for you to have dedicated equipment for the patient. For instance, the blood pressure machine, the glucose machine, sometimes the pulse oximeter. They will need you to have it dedicated depending on the kind of infection and transmittability of the patient you're talking about or taking care of. So it is important to know that. Now, I wrote something about the NCLEX tip. Uloma, by the way, if you have a question, please leave it in between. It says, NCLEX tip, if you're in doubt, choose hand hygiene. Now, what I mean in this sense is that if you ever think that, oh my goodness, should I choose hand hygiene, or do we need hand hygiene? Well, you need it. So if there's a question about safety, you already read the question, is like a patient or a nurse wanted to meet with a patient and the family that is going on discharge. Should the nurse use hand hygiene? By all means, go for hand hygiene, because like I said, hand hygiene is not just with soap and water, it is also with disinfectant, right? So the safer or the cleaner you are, so to say, it's better for the patient going home or even the patient coming in. So if you're in doubt, always go for the one that protects you as a patient, you as a nurse, sorry, and your patient. Now, we're going to go further to the transmission-based precaution. And there we have the three types that NCLEX will ask you on. We know we have the contact, we have the airborne, and then we have the droplets. Can you still hear me? I feel like this is kind of unusual for me to just be here talking alone, so I would need you to in between say hi, to say we can hear you, so I can keep talking. Even if I can see myself, I just feel like, oh my goodness, I hope I think what I'm trying to say is that it is boring to talk alone if I don't see your comments. So leave your comments and say, yeah, I'm listening. If you have a question, leave that. So now we're going to go to the points, the transmission-based precaution. We started with the standard precautions. Okay, good. We started with the standard precautions that you would do for all the clients. Now we're going to go to specific. I want you to really think about these three, and you need to know this. Whatever I'm teaching you a high yield content. High yield content meaning that you will likely see it. So if you've gone through the download I left in the WhatsApp group, it shows the areas that NCLEX will test you on. And there is no way you will do the NCLEX without being tested on this. Okay, so you will always be tested on the transmission-based precaution, maybe one or two. So it is important that you know where to classify it. Now, I have to say from the beginning is NCLEX will not ask you like a patient has contacts or falls under the contact precautions. What are the equipment to use? What are the precautions to use? No. NCLEX will not ask you. What they will say is a patient has the MRSA or C. diff and all that, or the RSV. What are the precautions you need to take? Something like that. That is how they will put it. So what they want you to know, or what they expect you to know, is that the MRSA, which is the MRSA, the C. diff, and the SRV, and wound infection, they come or fall under the contacts. I think that's what I wrote here. I said what, and then what they are trying to ask, whenever you see these transmission-based precaution, they're trying to know, do you know where to put it under, how to classify them, and do you know the relevant personal protective equipment as a nurse you need to wear? So for the contacts, we have the gloves. Like if as a nurse, if you're going to meet the client, you need to put on your gloves, you need to put on your gown, and you need to keep that client in a private room. Why? Because we're trying to avoid the transmission of that infection to other clients, to other patients that come in. You don't want a patient to come into your care and leave with even more diseases, and that is why NCLEX will be testing you on it, especially the CVs. The Clostridium difficile and the MRSA, they are easily transmittable. Now, remember dedicated equipment. If this patient has C. diff, You don't want to use the pulse oximeter you used for that client for a healthy client. And sometimes in NCLEX, like the next gen, they may ask you, or they'll put a lot of different patients, and then they will ask you, can these two clients stay together? And that is where the cohort come. So if it is the MRSA, you can leave both of them together in the same room. It doesn't have to be private. If you understand, say I understand. Okay, you can both clients that fall under the same category. So if they are under the contact, then they will be under the same room, or they'll be in the same room. It is safe to put them in the same room. Why? Because anyway, they have the same diagnosis, and nobody's going to be infecting the other. They already have it, right? So you put on your gloves, you put them in a private room, and the cohort is putting the same client with the same illness in the same place or in the same room, if you're short of room. If not, you can always leave them to be in their own private single room. But you never put a client with contacts and a client with droplets. If you understand, please tell me, yeah, I understand, so we can go further. Okay? I'm waiting for your response so I can go further. Oh, something else I added to this contact is that when NCLEX is testing you, it's not going to test you on, for the hand hygiene, be very careful. It's not going to tell you to use hand sanitizer over using soap and water. Why? Because in these ones, you're coming in contact, like the wound infection, you're coming in contact with bodily fluid. So if there is an option with C. diff, you must use soap and water to kind of wash the germs away. Now we're going to talk about the droplets. Tell me if you're here. We're going to talk about the droplets, and one thing I used to remember the droplet is the, let me write it here, PIMP, like pimp. It's a mnemonic that I've used. So the P here stands for pertussis, then the I stands for influenza, which is the normal flu. The M stands for meningitis, that's inflammation of the brain, and pertussis. So PIMP, if this helps you, I'm just going to highlight this. So I said PIMP droplet. So you pimp the droplets. Pertussis, influenza, meningitis, and mumps. They are the ones that fall under the, let me write, mnemonics. Okay. You can also highlight this. Okay. So what are the personal protective equipment you need to wear? The surgical mask. In droplets, you put on surgical masks, and you have to do it within 3 to 6 feet, right? And go ahead, yes, good. Then there is a need for you to put on the gloves. You need to put on the gown if secretion is likely. Now, the underlying word here is, are there secretions? Are there bodily fluids? And of course, private room. If there is an option for them to stay in a single private room, by all means do it. But if you have a patient with meningitis, I'm shouting this and repeating myself, this is for emphasis. If you have a patient with meningitis, you have a patient with pertussis, you can leave them in the same room, but you cannot put a patient with meningitis and a patient with C. diff. No, because they have like two different groups. The meningitis is under the droplets, right? And then the C. diff is under contact, so you cannot put them together. Okay. Now we talk about the airborne. The airborne, what I used to remember it is air, like you watch television on air. We are on air, and there is this MTV. I'm going to put this for you. MTV. This is what I used to remember airborne diseases. and the precautions. I'm going to highlight this. So MTV, meaning the measles for the M, the tuberculosis for the T, chickenpox, which is also varicella. And they've also added newly this SARS. Now, one thing about the airborne is like they are the cocoa. They are the head of all the infection, and they are really critical. If this helps you, like, they are number one. They are up in the air, and that is why you can watch them on the TV, MTV, right? This is just a reminder for you. So, and because they are up there, you need in the air. The air is not so good, so you will need a respirator. This is what I use to kind of remember my, put a memory to remember it easily. You need the respirator, and this is the only one you use the N95 respirator, like the mask, and the negative pressure. And now, one thing you must do, and NCLEX love asking this. One thing about NCLEX is that they will ask you things that people are not usually, or people who likely not know, except that you are diligent in knowing. One thing they may likely ask is, a patient is about to go for a pee, or to greet his friend or a family, or is going to receive flower from the nurse's room, and this patient has, for instance, chickenpox. What are you going to ensure that this patient has? Sometimes, if you choose the hand hygiene, well, duh, everybody needs the hand hygiene, right? If you choose the patient needs to wear gown, well, if you've noticed, most of these people, they wear gowns, right? And in this case, yeah, most of these contact and droplets, there is a need for gown. But something that is very important is that before the patient leaves his or her room, let them put on a mask, because even the air they breathe, remember it's airborne, even the air they breathe can affect all the nursing staff and all the clients. So very important, if there's anything you need to remember in airborne, is that they need to put on their mask before leaving the room. NCLEX, they love asking those detailed questions that everybody needs to know. Oh yeah, I did write here about the NCLEX tip. Hi, if you're joining here, welcome. Please leave a hi so I know that you are here. And in between, if you see there is this love sign, please try to engage, like tap on that in between, so that YouTube will suggest this video to other people. Let's help others to find this video. Okay, that being said, we're going to go to isolation and safety priorities. Again, these are high yield content. So I am not asking you, or the question is, should I know it? It is, you have to know it. If you're going to write the NCLEX, you must know these things. Now, for the isolation and safety priorities, we have here in the US and Canada, they have the dawn and the dolphin, right? Let me know if you understand the dawning and dolphin. So for the dawning, what I used to know the word is, in the dawn there is ON, meaning you're putting on. Then in the dolphin, I wrote PPE remover, but sometimes they don't say removal, they say dolphin. So I'm going to put the word dolphin. So / dolphin, and you can see highlighting the word, meaning you're taking off. Now, what NCLEX wants to know is, this nurse that I'm going to give a license to practice as an RN, does she know what it means, or the way she needs to take out her personal protective equipment, or gowns and gloves and all that? If you don't know how to do that, it means that you're going to be an unsafe nurse. Again, we're talking about safety, and safety is very important for NCLEX. When I was preparing for my NCLEX, one thing I learned is that NCLEX is a safety exam, and this is by Nurse Mike. He said that NCLEX just wants to know that if they leave you and you're the only RN in the entire world, and the world is depending on you, that you know how to make safe decisions for yourself and for your clients. So everything around NCLEX is safety, and that's why I wanted us to start with this, because if since it's the first thing, you will likely remember it. So PPE, how do you put on your personal protective equipment? You first of all put on your gown, and then you put on your mask, you put on your goggles and the gloves. Tell me if you have a mnemonic for this. Okay? Tell me if you have a mnemonic for this. Gown first, mask, goggles, and gloves. And then the doffing, which is how do you remove, by the time you're out or you want to go out of the patient with, let's say, a droplet, right? How are you going to take off the personal protective equipment you've put on? So they say you have to start with the gloves. Why? Well, let's think about it. It makes sense, right? If you've already touched bodily fluids and all that, you don't want to carry that bodily fluids and now you're taking off your glasses, you've already touched your face, you're taking off the gown, you've already put it on you. So they say, first of all, take out the dirty things from your hand, because at the end of the day, you're going to be using those hands to take the rest out. So take off the gloves, and then you can take off the goggle, and in the goggle you can just put it inside and take out the gown. It is only after then that you cannot touch your face. So gown, your gloves first, and then you take out the goggle for you to see well. At least this is my explanation. And then you take out the gown so that you'll not be too hot, and then the least, which is the mask. Now, another thing that NCLEX loves to ask when it comes to safety is when you are in a ward or you're going to give a patient food or medication, you notice that the alarm just went off, the fire alarm just went off. What do you do? Now, they have this RACE plan, which is the R stands for rescue, the A stands for alarm. So first of all, rescue yourself. Rescue the client. That's the number one thing. That is the safest thing. If there is any other thing you need, if there is only one thing you can do, it is to rescue. It is not for you to go press the alarm, because if you press the alarm, first of all, the fire is going to come in and you're going to be consumed with the client. So first of all, take yourself as much as possible and take the client out. And then you can press the alarm. You can try to contain. Containing is, oh, the fire is spreading. What are you going to do? Close the door, right? Go under the bed. Try to take away the oxygen cylinder away, because that is combustion itself. So take that away. And it is only after then that you know you're safe. You've already called for help. You've already contained it, like close the door, close the fire, use the fire door, the window, and all that you can now help to quench the fire. So this fire safety is RACE. R again start for rescue yourself, rescue your clients, safety first always, and then alarm, contain, and extinguish. Okay, I wrote some of the things, since we're still talking about safety, I wrote some of the things that NCLEX, you may see jump in every now and then, especially when you're doing your U-word practice question. First thing is keep bed in the lowest position, especially with the elderly. You actually don't want to keep the bed very high, because what happens if your client wants to come down from the bed for a pee and all that, the patient is going to fall, and you don't want to do that. You don't want the patient to fall and sustain another injury and stuff like that. It's a lot. So they want to see if you understand what it means to maintain safety by just lowering the bed. And then the next thing is the side rails, because some people can just kind of roll and fall off the bed. So the side rails on both sides, and always keep the call light within reach, even if this person is an adult, one that is not old. As long as you see put call light within reach, choose it. If there is an option, I'm repeating myself, of do anything that is safety based, don't look at the age, put it, okay? And The other thing is sometimes they may want to ask about non-slip socks. It is always a good idea for your patients, especially the elderly, to have non-slip socks. Why? For friction and adequate lighting, and by all means declutter the environment, because if the environment is cluttered, scattered with all the things that doesn't need to be where they are, there is a high risk for fall. They will sleep, a lot of things that can be prevented. So yes, declutter the environment. And for people that have high risk, like the memory problem, the Alzheimer, dementia, the elderly, people with hypoglycemia, confusion, head injury, they have high risk for fall, right? So you need to have frequent checks. And of course, it is important that when a client shows the risk for falling, then you need somebody to be there, and you don't necessarily have to be there, but as an RN you have to think, who can I delegate? We have the PSW here in Canada, and then in the US there is the unassistive or unlicensed assistive, the UAPE, and NCLEX actually uses this word UAPE. And then I added this rugs for elderly. When they say that allow the patient to have rugs, or suggest that the client should have rugs in the house, or a patient is trying to move to your facility and has a nice rug at home, would you advise that the client come with a rug? No, no, no. Even if you can tape it, in NCLEX situation it is a risk, so no to rugs. Okay, that being said, we are done with everything about safety. We're done with isolation, how to ensure that the client is safe and preventing of fall. Now we're going to go to prioritization of care. I did my research, and I noticed that according to the NCLEX plan of 2023 to 2026, prioritization of care comprises of 6 to 12% of the total NCLEX questions. But I do think that prioritization is not just this particular one, like limited to which client you see. I feel that prioritization is the core of most of the questions you see on NCLEX. So I thought that if there is anything we need to start with, is prioritization. Now, I have made a long list which we're going to go through just for you to understand what this prioritization means. I have gone down onto the deep dive because I know that once you understand prioritization, I can beat my chest that the next NCLEX you are going to pass. The very first NCLEX you write, once you understand prioritization, you are going to pass, and I'll be here to say congratulations in advance. Okay, let's go ahead with the prioritization. So NCLEX uses the Maslow hierarchy of care, which is physiological, like the bottom, right? We learned that in our nursing school. The bottom is airway, breathing, circulation, fluid, nutrition, like the basic needs of your clients comes first. So whenever you need to say, okay, this client has this care, this client has this concern, what should I look for? You always go for physiological over safety. So it is after you've taken care of their feeding, if they need to go, if they are constipated and all that, are they breathing, are the air tracts occluded or something, then you can go to safety, which is protection from harm, like in fire and all that. There is love and belonging, self-esteem, and self-actualization. Now, a tip I wrote is that always stabilize the ABCs, which are the airway, the breathing, circulation, before any other need. So if they're talking about a patient is complaining of or needs education, no, a very good example is you are taking care of a client, a teenager that wants to meet her friends, which is very typical of teenagers. They want to have time with their friends. They feel like they are missing out in life if their friends age group are not with them, but they have asthma. So they will be asking you to see which one to do first. Will you first of all give them their medication or go call their friends? And that is where the ABC comes in. First of all, give them the medication to open their airway so that they can breathe and have the oxygen in the lungs to call other teenagers. Okay? So the other guiding principle you need to know when it comes to prioritization is airway is most critical. If there is any obstruction, any anaphylaxis, any severe asthma, you need to take care of that first. And it is only after then we go to the respiratory distress and to check if the oxygen saturation is low. Sometimes oxygen saturation is not that important depending on the client's background. For instance, we know that a normal client, healthy client, will have like 95 to 100% of oxygen saturation. So once it falls to 90, you're like, oh my goodness, something is amiss, something is wrong. That's like red flag, right? But a patient with COPD, it is chronic. The lungs are already used to low oxygen, hypoxia. So if a client with 90% of oxygen is like, I need or I'm having pain, or I have 90%, it is not so important compared to a healthy client. And then it is after we've done the airway breathing, then you can go for the circulation and vital signs. Now for the vital signs, it is always important to understand that if it is unstable, we know the normal blood pressure 120, right, over 80, but then you see that, oh my goodness, is 180. This is so abnormal. You need to take action. Okay, that being said, then the third one is acute versus chronic, stable versus unstable. What we're talking about is what will help you, guide you when you want to prioritize, because NCLEX is big on which client do you see first, which would you assign, which one needs your care, what would you do in this case? Are you able to understand that there is a safety risk? Are you able to understand that these clients can be safely delayed within 2 hours? You can go and meet them and they will still be alive? Or are you able to understand critically what it means to triage that the one complaining of sudden chest pain will receive the first care, because if you don't, the next minute they're going to die? Do you understand that? That is why we're talking about prioritization, and these are the things that will equip you to know, okay, this is unstable, airway comes first, every other thing can wait, right? So when you're thinking about it, understand that, or read between the line. One thing I have to say is that NCLEX is very tricky. You need to be very detailed. So one of the things I do things I did, and I told myself during my practice time using U-word, I would use my finger to touch the word so that I'm very sure that I'm reading between the lines, because sometimes it will start with, this client is gasping for breath 2 hours ago, and for now the client's oxygen saturation is 98, but then there is another person with chest pain that just started. So when you see gasping for breath and all that, you would want to go and pick that first one. But remember, a go, and then they also want you to know that the oxygen saturation is good, meaning that it was unstable, now it's stable. But then there is a new client that needs your help, that you need to prioritize. Okay, so newly admitted and post-op that is less than 12 hours will always need your help, will always be first on your list over one that is chronic and stable. And then another one to help you is unexpected signs and expected signs. So using the example I said about chronic obstructive pulmonary disease, which is the COPD, it is expected that a client with COPD will have like 90. Why? Because it is chronic. These patients have lived all their lives, in this case, let's say all their lives, with lungs that are hard to breathe. So when it's 90, you're like, oh, you're doing well. But when it comes to a patient with asthma or patient post-op has been in bed and has sudden chest pain, there is dyspnea, oh my goodness, tell me in the comment section what you're going to suspect. Pulmonary embolism. Put that in the comment section. Pulmonary embolism. Why? Because they've stayed in bed. So it could be that they've had this DVT that has dislodged and now is straight in the lungs. So you need to take care of that. So we need to understand what is expected, what is not expected. And then there is hemorrhage, there is hypoglycemia, and high fever of 104 is equal to. Now, I need you guys to remember this. Any fever that is more than 104 is an emergency. When it comes to prioritization, it is an emergency. You need to do something. Okay, now I have one example for us, and I'm going to pause for you guys to answer this question. It says, who do you see first? Now we have a client. Number one says a client on COPD. So a client with COPD has 2 liters of oxygen and the saturation is 90%. The second one is new post-op with 250 50 milliliters of bloody drainage in 1 hour. Who are you going to see first? The third one is stable diabetic with blood sugar of 200, and the fourth is dementia patients wandering but safe. I'm going to pause for you guys to just type in the comment section 1, 2, 3, or 4, and if you can add why. If you're watching the replay, you can also answer. If you're watching the replay, you can also answer. This actually helps you to. I would just suggest that you pause the video and answer and see if you got it right. This is like a practice for you. I'm waiting for your answer before we go ahead, okay? Tell me which clients would you see first based on the prioritization I've explained to you guys. Is it 1 or 2 or 3 or 4? Ulom, are you there? Sis? Okay. That's number 2. Why did you say number 2? Why number 2? Because I know that some people may be like, oh, number 1. I think you taught what I was thinking. In a new, now it says new, that's the word I gave it out, new. There is post-op, right? And then it says 250 milliliters drainage in 1 hour. It should be less than 100. 100 or less is normal, but we're talking about 250. What does that tell you? There is a new bleeding. And this is something that you may need to rush back to the surgery. It's a medical or surgical emergency, so you cannot have 250 bloody drainage in 1 hour. The COPD, it is chronic, it's stable. Now the number 2 question says stable. It gave it away. Stable. Thank you. That is your clue. It is the patient we're talking about is stable. And then they said dementia patient wandering but safe. So it could be that dementia patient was wandering with a staff nurse. Information wasn't given. Wandering in the hospital facility but safe. Safe, it could be that, well, somebody is looking at or the camera is there. The patient doesn't have any gun or something. So as long as the patient is safe, written there boldly, we will need to run for the medical emergency. I'm going to read your comment. You say, I will see number 2 client first. Perfect. Okay, let's go further to delegation. Now, for this delegation, we're going to be talking more about you as an RN. What kind of things can you delegate and who can you delegate to? Because at the end of the day, when you delegate, you still retain the accountability. If something goes wrong, you'll not be like, oh, I gave you that patient. Well, you gave me the patient, but did you ask if I have the relevant education experience to do that? So that's one. The second one is you gave the clients, but something changed. When you gave the clients, the client was stable, but now the client is unstable. There is headache, there's chest pain, there's breathing problem. So it comes back to you. Delegation for RNs, they are not final, right? Okay. Then the UAP, the unlicensed assistive personnel, we need to know that. Okay. So if there is anything you need to know, I think I learned this when I was preparing for my NCLEX, is that nurses are the only ones, RNs, when I talk about nurses, I need to specify RNs, you, Uloma, me, Roselyn, my responsibility is assessment. That is why I'm being paid how much I'm being paid, right? So you remember, I hope that when you're writing the NCLEX, you remember that I am being paid to assess. As an RN, I am being paid to do all the assessments. So as a patient is coming in, that's why they are giving me extra money, right? I'm going to do the initial assessment. I'm going to do the admission. I'm going to do the post-op care. I won't give it to LPN, even if they are overqualified, they have years of experience. As long as I have the hats and I'm wearing my name tag RN, I'm going to do that. All unstable clients will come back to me. And every new client comes to me. You cannot delegate that. Now, teaching is also my responsibility. I think it's part of the things why they pay me how much they pay me. If you remember this, if you remember, the reason why they are paying you more than the LPN is that you are going to do the assessment, you are going to teach, you're going to evaluate care, and you're going to take care of the most difficult patients. Okay? So our role as a nurse is to implement the nursing process. And a rule is the ADPI. When it comes to assessments, the diagnosis, the planning, implementation, evaluation, these are the things you as an RN, you've been equipped throughout your nursing school to do. So you will never delegate that to someone else. Okay, now what can the LPN or the LVN, sometimes they say the LVN, sometimes they say the LPN, but in NCLEX, when you use the U word to practice, you always see LPN. And when it comes to the PSW here in Canada, you will see them as the UAP. Okay, unlicensed assistive personnel. So the LPN, they take care of predictable, like a patient had been in the ward for, let's say, 3 days and is planning to take medication, or there is a medication round, you can give that safely to the LVN because they have the license to give the rounds or to do the medication pass. Now, they can also collect data. The data could be taking vital signs and recording them. They can do the input and output. They can do yeah, everything like fluid balance and all that, they can do that, but they will never start the initial. So if you need to do the iron input and output when a patient has, for instance, diuretics and all that, you will do the first one, but they can continue because they have the mind that if you have done the first one and you're delegating this responsibility to the nurse, to the LVN, you must have said, hey, these are the things you need to check out for. So NCLEX already assumes that because you've done the first one, there is the baseline, which of course it is. There is the baseline which they will build on, right? So that if something goes wrong, they'll be like, okay, this was the baseline, and they can go back to that baseline. And one thing you need to know is that they can teach. Even if we're talking about that RNs are the only ones that can teach, the LVNs, they can teach, but they are not doing the first teaching. They are going to reinforce whatever you say. It's just like the doctor. When you say that the doctor has prescribed this medication to you, and the nurse or the patient like, okay, what is this medication? You can tell the patient that the doctor prescribed, for instance, insulin to take care of the diabetes, right? You can tell that. So that is what LVN does. They will reinforce what you've said, but they will not bring from the scratch and say, this is what you need to take. So they are only going to build on the information you've already given to the client. Now, LVNs can actually administer most. When I say most medications, yes, I did go for an interview in a surgical ward recently, and I was asking the nurse in charge that was interviewing me, and she's like, LVN can actually give IV. In Finland, LVNs, LVNs, they don't give IV. Now, based on policy, but in the NCLEX, they want you to know, and they are going to state it. If in the writing they say that according to the hospital policy, IVN, the LVNs can give they can go into the artery. Remember that they cannot push. That's why I highlighted except IV push. They cannot do, never, because it's not like they are not equipped, but their license don't give them, they don't have the right to do that. I'm going to highlight this. The license, the responsibility, and the everything around their license hasn't permitted them to give an IV push. It hasn't permitted them to give chemo. It hasn't permitted them to do blood transfusion. It is only the nurse, that the RN, that can do that. So yes, they can give meds, but there are clauses, there are things that there is an extent for them to do. So it is important. And one thing about NCLEX is that it doesn't test you on things that's kind of normal, right? It doesn't test you on that. It tests you on the abnormal, the things that you need to know. This, again, the safety things. So they say that a patient can, you're delegating to an LVN for IV push. They want you to know that an LVN cannot do that. So one thing I learned when I was preparing for my NCLEX is that when it comes to blood transfusion, when it comes to chemo, when it comes to push, is a no-no. Okay. And sterile procedures like the Foley insertion, wound care, track care. Now, again, this depends on policy. But when it comes to, someone said, can they give? Yes, they can give IM. They can give IM, especially here in Canada, US, they can give IM. But they just have things that they cannot do, because even in Finland, there are some extra courses that these LVNs, they do, and it gives them the right for them to give IM. So yes, they can give IM. Imagine if they can give into the vein, it means they can give IM, right? So keep your questions coming. You said, can LPN give injections? Yes, they can give injections, just some injections that are kind of restricted. One thing that I need you to know is, even if it says that they can give IM, you need to check the word around it. Did it say that it can give, or if there is a medication, they say this is a new medication, the client is on a new admission, or the client is about to go on discharge, can you delegate? Because there are clauses that will state that, hey, I know they can give, but in this situation, no. Do you understand? Okay. So LPN, they cannot hang, they cannot push, they cannot evaluate. I think this is going too deep. I'm going to share, it's already over 1 hour and I wanted to stop on the first hour. So I'm going to share this document for the NCLEX prioritization deep dive. This is for you to kind of go deep, to know the kind of, so NCLEX prioritization deep dive, for you to know the kind of care you need to prioritize, how to go about it, and even the lab values, which one, because lab values, they have grade, right? So not all lab values are equal. Some of them are like top notch, they are the baba. When they are sick, everybody's like, hey, you go and attend to this person, because we need this person to be alive. Like the potassium, the sodium, we need them to be alive for other body functions to work, right? So the magnesium and all that. I'm going to leave that deep dive, or I'm just going to go within 5 minutes, go fast, like unstable trumps stable, acute will always trump chronic, unexpected will always trump expected, time sensitive. Sometimes they will say like stroke signs and symptoms within 4.5 hours, like thrombosis syndrome, the STEMI, PCR and all that. And then least invasive or least restrictive when it comes to safety will always be better than invasive. So for instance, least invasive, what would I say? Restraints. I think what comes to my mind is restraints. If they're asking you that a client has been confused, restless and all that, would you put the client on chemical restraint, like give medication, or put some kind of chain to the bed with doctor's order? Understand that they will also say with doctor's order, meaning that is also right with doctor's order, but are there other things you can do? So the least restrictive, the least invasive, like, is there an option for a sitter? If there is an option for somebody to sit with the clients, to sit with the patient, please go for that, because that is least restrictive or least invasive. Okay. So actual problem over potential problem. So if they tell you that a patient thinks that he's going to be sick in the next 2 hours, well, it is in the future, but there is a client that is already sick, has nausea, has vomiting. You will take care of the ones here. It's like counting your money. You know you're going to be paid something and you're already budgeting for something that has not entered your account. No, what you budget for is what you already have in your account, not something that will come, because maybe the bank will go on holiday, they can change their mind, your employer may say no, we don't have the budget, it's going to come in the next year, something like that. So you only budget what you already have in your account, not the one they've promised you, right? I hope these examples will actually help you to remember these things. We have a lot, but we don't have time to go through. So I'm just going to kind of go fast. Now, we have the high risk labs that I need to talk about. And if you don't want to memorize anything, these ones you need to, because potassium, what do they do? Contractility of the heart. If the heart is not working, the lungs, that's the best friend of the heart, will give up, like, oh, you're not talking to my best friend, I'm not talking to you. They are always choosing sides. So the heart and the lungs, 5 and 6. So potassium needs to work. Now, a question: what is the normal range? I had put in the WhatsApp group. Remember this. What's the normal range of potassium? Please leave that in the comment section. Because if it is low, there is a problem. If it is high, there is a problem. So that is why we need to know the range. Potassium 135, 145, potassium, that's sodium, sorry. Then potassium, we have 3.5 to 5.5. You need to know these things, okay? And glucose. Now I've written what will happen if it is over 6, what will happen if it is under 6. You need to go through this. Okay, I think that's all. Yes, thank you, Loma. You do know it. I'm already rooting for you. After this question, we're going to do the question and answer now, but I really suggest that. Good. Something I wanted us to talk about when I was preparing this is that this is really going to help you guys. It's called the mini decision tree, and you can use that within 10 seconds. This 10-second rule is more of if you're very confused and you're like, what do I do? You know, your gut experience will tell you this is the best for you. And this is it. When you look at the question, you're like, all of them look the same. But one thing that will help you is you ask yourself, is this patient going to die right now? Is there airway? Is there breathing? Is there circulation and bleeding? Is there anything around this? Do I need to act now? If I don't act, this patient is going to die. That is kind of a decision tree for you. So it means that you need to intervene now. And then, is this patient stable or acute? So stable or stable. Sometimes they will refrain or paraphrase the word like the patient was in the past. So you need to know, is it in the past or is it going to happen now? And what else? Any time. So is there a critical window like the stroke, the myocardial infarction, sepsis, or the postpartum hemorrhage? Because those are emergencies, they will not be safely delayed. I'm going to repeat myself. These myocardial infarction, stroke, sepsis, they cannot be safely delayed, because if they do, maybe the brain will not be working. They will be speechless. The slurred speech is going to continue for stroke patient. Myocardial infarction, the heart will stop working, meaning the lungs will not work. Sepsis is going to go systemic, and then meningitis, a lot of things involved. Postpartum hemorrhage, the woman may die. You need to act fast. You need to intervene, right? So there is least invasive and safety first, unless the patient is crashing and there is a need for you to evaluate, is the thing actual or potential? So is it physiological or psychological? And again, assign or delegate only after you identify instability. Okay, if there is a question in, let me see, let me open this chat because from my phone I can't see. Your call is in another window. Okay. Show on stream. It says, if there is a question on airway and bleeding, which one would you choose first? Remember, airway comes first. That is why we have A, B, C. A comes before the bleeding, right? You choose airway before the bleeding, always. And even after the airway, we have the breathing before circulation, before even the bleeding, okay? Okay, so the other thing I wanted you guys to remember, because this NCLEX, oh my goodness, it is tricky. I told you, I think I was speaking with Uloma and I was telling her that you see the question and you feel like you know it, but somehow you're like, what is the right answer? That is how NCLEX tricks you. So sometimes you may think you know it, but no, trying to figure which one is the right answer may be a problem. So I wanted us to know or to talk about the common traps and how to dodge them. So the first one is calling the provider too early. In NCLEX, if you're not hearing anything, hear this one. In NCLEX, they are testing your knowledge. They don't want you to, first of all, run and go and call somebody. So when a client comes, they want you to, first of all, do something. That is why you've gone to nursing school. You can do something. NCLEX believes in you that you can always do something. So if it means checking airway, do it before you call the provider. Because when you call the provider, what would you say? You saw the client on the ground. Okay, and what? Did you check the pulse? Did you check the respiration? You don't want to act, you don't want to present yourself like you don't know what you're doing. NCLEX doesn't want you to do that. So you need to say that this is the background using the S bar. This is the situation. This is the background, right? These are the assessments and these are the recommendations I want you to do. How can you recommend when you've not done your due diligence, when you've not done your own thing? So yes, call provider last if you have to, okay? But you need to do something. For instance, they say that you came to a client or you started a transfusion and the clients started having an anaphylactic reaction that is chest tightness of chest, if I can talk, sudden obstruction in breathing, deep sneer, coughing, and all that. They don't expect you to run and go and call the healthcare provider. They want you to do something. What would you do? Stop the infusion. Start IV access. It is only after you've done that that you can now say, hey, this client 56 in this ward and all that, this is what happened. I have stopped the infusion. I've done this and I've done that. And sometimes they even want you to go for that. When it comes to anaphylactic reaction, what do? Epinephrine. So sometimes they may even try to ask you in the next gen, what are the things to take care of? That is why the next gen is not testing if you have the clinical skill. It wants to know that you have the critical thinking that, okay, epinephrine is used for anaphylactic reaction. Corticosteroid is also used in some cases. That am I able to prepare it? So sometimes it's going to ask you, what are some of the medications, especially in the next gen? That's why I love next gen. What are the things? So you as a nurse, you'll be like, okay, I have assessed the situation. I've stopped the transfusion. I know what is happening. I've maintained IV access. I've removed the old line. I'm going to prepare the epinephrine. I'm going to prepare corticosteroid. And then I'll call the HCP. Now the HCP could be the doctor, it could be the nurse practitioner, but you know what you need to do. If, again, this is the example I'm using, if you are the RON in the whole world, do you know what you can do to keep the client safe? Okay, I think it must have entered your brain. You definitely following me what I'm saying. If there's a question in the bleeding, which, okay, yeah. What were you laughing at, Oloma? So let's go to teaching and evaluating. Teaching stroke evaluating before assessing or stabilizing. What did I want to say about this? Oh yes, you cannot start teaching. You cannot start teaching if you have not assessed. What are you going to teach? Do you know my problem? It's like you're giving me advice and you don't even know my problem. So you first of all do your assessment. Remember ADPI, you assess before you get diagnosed. Because it is useless to say, Rosalind, you want a child. No, I don't want a child because I have children. So you need to ask me, what do I want? I want my friends to pass NCLEX. Then you know how to help me. Then tell me that I want a child. I already have one, right? So you need to know my need. You need to know my problem before you give me advice, okay? Then doing diagnostic before simple corrective plans. So, oh yeah, you need to elevate the head of the bed, you give oxygen, stop transfusion. Okay. What was I saying here? So these are some of the common I'm trying to understand my thoughts when I wrote doing diagnostics before simple corrective. Oh, again, I think what I'm trying to say here is do not diagnose before helping. So if a client has a problem with, there was a time that a client came and she had low blood pressure, right? You don't first of all tag the patient as hypotensive client. You first of all help that client If you need to elevate the head of the bed, if you need to put IV so that the blood pressure will kind of go up, if you need to give medication, you do that before you already give a diagnosis, before you start writing the plan. So you do your assessment, but intervene. I think what I'm trying to say is intervene before you tag them. Help me first before you call me hypotensive. Okay? Then, choosing restraints before alternatives. Do not first of all try to restrain your clients before checking alternatives. Are there other things I can do? Can I talk to the patient? Can I use music therapy? Can I delegate UAP to go and sit with them? Maybe that will calm their nerves. Don't first of all rush to go and use the restraint that the provider prescribed. No, do other things that are less invasive before. So those are traps you need to avoid. And again, delegating unstable patients to LPN are traps you need to avoid. And chasing numbers without the patient's picture. Again, you cannot say a patient has this, a patient has that without doing your assessment. Now, I have to say, I think I missed it, but something I need to say is assess before care plan. Assessment, or I think managing before assessment. And this is not just NCLEX. In real life, one of the interviews I went for, the two interviewers, they're like, you came into the ward and it's like a morning shift. They've given the report to you. What do you do? What would you do? Don't believe your colleague. Let me drag your ear. Do not believe what they tell you. Why? They could give you a report saying that, Rosalind, I'm handing over to you 4 clients. One in room this, one in room that, one in room this. What do? After you've taken over, go back and do your assessment. Go and see if they've handed dead patients to you. Because the patients may die, and if the patient may have died, but the nurse didn't want to report because she did not want to do last office. She did not want to say, I don't know what happened. So it is to your own security, peace of mind, your own protection of your license to go and do your assessment. So don't go and say, oh, thank you for the thorough report you gave to me. And then you're like, okay, this patient will be number 1, this patient will be number 2. No, go back. Yeah, I'm explaining. Go back and assess the client. Go back and see what the client needs. Go and see if all the clients that have been given to you or assigned to you are even alive. And it could be that when the patient, it could be that your colleague gave perfect reports, but situations change really, or the situation may just change fast. You cannot bank on your assessment, bank on how you're going to take care of them based on what they have said. So you need to do the assessment. So don't chase numbers without a clear picture. Don't go and be saying, okay, this is number 1, number 2, number 3, number 4, without doing your assessment. Go back and do your assessment, okay? Okay, so I said managing before assessment. Chasing numbers without the patient, yeah. Symptomatic beats asymptomatic. You said I should explain what chasing numbers mean. For instance, a high blood pressure. Someone may come in and say that I have, or you check the patient's blood pressure is 160/80, but the patient doesn't have pain, no headache, no dizziness, no rolling of the eyes, no what is it called? When they try to stand, there is no, the balance is perfect. So they are asymptomatic, they don't have any symptom. But then there is another client, the same blood pressure, the same blood reading, 160. But then there is dizziness, the eyes are closing, they are seeing double vision, bipolar, double vision. they have pounding headache, that's the one that needs first care. Even if the background is the same female, the same age, as long as there is symptomatic, it is not just the number. You have to get more information. You have to see the signs, like unique sign to say this comes first. Uloma, did I answer your question? So, I think that's how to practice. Let's talk about NCLEX. You say how to practice and think like the NCLEX. I know that some of you will be using your U word to practice, which I highly recommend, especially a month or two before you go for your NCLEX. You need to do your U word. This is my strategy. U word hasn't paid me. I hope they do in the future, but this is what helped me. So, force the ladder on every question. This is what I was telling you, that you need to circle, you need to underline, you need to read between the lines when you are reading, because NCLEX wants to test if you're detailed or enough. So you have to be very detailed. You have to read between the lines for you to understand, and speak your rationale. Why are you doing what you're doing? So when I ask you, why did you choose number 2? It's because I wanted to know, do you understand why that comes first? So it's not like because I said it. You have to be convinced on your own that this is the reason why I'm going for this, not just because she said it or not just because it looks good. You need to be convinced, because once you're convinced, then you're good to go for any question. Again, the principle are the same. It's just a different question, different paraphrasing. So once you understand your principle, you're able to answer any prioritization question. Okay? So I choose this because it stabilizes breathing now, and the patient is unstable and new. It is convincing. So build if ties rule. So if 2 look urgent, pick the one that changes airway and breathing first. It is only after then you can go for circulation and then neuro. Now, review after each question whether a faster, safer, less invasive step in this. Okay? Now, we're going to do a question and answer. I have 26 questions for you guys, and I want you guys to be fast. Okay? The questions, I have put them under prioritization, I've put them under delegation, safety, infection control. So let's go. Are you guys there? If you're ready, please type yes, and I'm going to be reading the question out. Once you tell me the question, I'm going to review the answer, because I think with all with the lecture, you should be able to answer these questions. So tell me, I'm ready. Just type I'm ready, so I know that Uloma is here. We have other people that are not talking, so Uloma, I'm just going to be mentioning you. Say I'm ready, and we know we're good. Yes, good. You keep saying yes, you didn't say I'm ready. So are you saying yes for something I've said in the past, or you're ready for the question? Say I'm ready. Let me know, so I know which state, because I noticed that the life is kind of. Oh, perfect. So the number 1 question on prioritization is, the nurse is caring for 4 patients. Which should be seen first? Here it comes. Number 1 says, perfect. Martin, thank you for joining. It says, the nurse is caring for 4 patients. Which should be seen first? Is it 1, COPD patient on 2 liters oxygen with saturation of 90%. And the second is 2-hour post thyroidectomy. So they have removed the thyroid gland, but now there is new worsenings and stridor. Or number 3, stable diabetic with a blood sugar of 210 milligrams per deciliters. And the number 4 is elderly patient requesting assistance to the bathroom. What do you think? Write A, B, C, or D. And if you can tell me why, just one word. One word that gave you the clue. And you guys, let's be fast so we can go through the questions. I have 26 questions. Let me see. You said, I see the live. I just joined. My exam is coming. Well, congrats already. And yeah. So Martin, have you given your answer? Yes, you said because of the new hoarseness. You're right. The new hoarseness mean that it's a complication of thyroidectomy. So, right? Airway is compromised and you need to take care of it. Now, what gave you the clue? That new. Or even if they say 2 hours, but there is a new thing, right? Something is happening new. And that's the red flag, acute, new instability. So I need to act right now. You're right. Now, if we take B out of the equation, we can now look at the patient with COPD, right? You can look at the patient with COPD or we can look at the patient with diabetes. But the first one says that stable diabetic patient, and we're like, okay, maybe the insulin is just, they've already administered the insulin and it's working. But that new hoarseness gives it away. Okay. The number 2 is new and stridor. Yes. The number 2 question is delegation. So which task can be delegated to a UAP? UAP is unlicensed assistive personnel. Which one can you delegate? The number 1 is assisting a stable patient with feeding, teaching new diabetic how to use insulin pen, assessing pain after a need of, okay, when needed, opioid, or monitoring for hypoglycemia in diabetic patients. So is it A, B, C, or D? Which one can you delegate to UAP, the PSW here? Let's be fast, guys, so that we can finish this because I really want this live to end within, yeah. Okay, why did you say that? Why did you say A? Oh, I wish I can just bring you. I wish I can just bring you in. Yes, you guys are correct. A, because it is only the RN that will do teaching. Teaching is not even for LVN. Assessment, it is not in her jurisdiction. Let's say that's a lady you gave that. It is not in her jurisdiction. Now, look, they said monitoring. Monitoring is also assessment or evaluation for hypoglycemia. And A, no, it is not their business to do any of these, but they can. The word that gives it clear is that you are assisting. So the client is eating, it's just dementia. Dementia, most of them, they are very stable. So dementia itself is not even an acute situation. So dementia, stable dementia with feeding. Yes, they can do that. Okay. So let's go to safety. It says that the nurse enters a room and sees fire in the trash can. What is the first action? Now we're saying if you're not doing anything, do only one. What is the first action to do? What is the very first thing for you to do? Remember our race? Remember the race? Oh, Ruth, you're here. Girl, you and wisdom and knowledge. Thanks for being here. Wait, let's check what's the time in Finland. Ruth is here. Ruth joined. Yeah, in chat. 10, 11, 12, 1, 2, 3, 4, 5, 6 a.m. Okay. It's rescue all the patients from the room. Okay. C. Let's see if you guys are correct. You know, at this stage, I'm like, congratulations. Congratulations, because you're right. You rescue. The first thing is safety. What nclex is trying to ask you here is, can you rescue? Can you see that there is a problem and you first of all hide? So rescue the client, ring the alarm, contain. The first one is use fire extinguisher. That's already the last thing you should be doing. Then the second question is call. That is you sounding the alarm. Rescue is the first thing, it's like airway. Take them out first. Then D is close all the doors and windows. You're supposed to be containing. So that's the third thing you should be doing, contain. Okay, now I have to say that this can also be the other way. It could be that in the next gen they will tell you that the nurse had already removed the client, she's already called the alarm. What's the next thing? It is only then that you can now say, I'm going to close the doors and the windows. Okay, so infection control. Which patient requires airborne precautions? Remember our airborne? Uncle Kuma, thanks for joining. So is it A, influenza? Is it B, tuberculosis? Is it MRSA or wound infection or RSV? Let's be fast. I think I'm not going to be explaining. I'm just going to let you guys answer. But if I need to explain, if you need me to explain, please let me know so I can go back to it, because we have 26 questions. And I think if I go into in-depth explanation, we're not going to finish these questions. TB. Ulama says B. That's TB. Martin says B. Let's see. I'm gonna close by 10 max, so I'm trying to go fast. Okay, so yes, TB, you're right. Now we're going to go to another prioritization. Who should the nurse see first? The number one is A, post-op appendectomy with rigid abdomen and tachycardia. B is COPD with oxygen saturation of 89 on 2 liter, and C is chronic heart failure patient with 2+ leg edema and crackers. And then the D is diabetic, asking about insulin timing. So which? Is it A, B, C, or D? A. Uloma says A. One more person to answer, and then I'll reveal the answer. Oh, we don't even, let's see. And you were right. The reason behind this is that it is post-op. They just took out their appendix, but now there is rigid abdomen. What does it tell you? Maybe there is bleeding. There is already infection in the abdomen, and the pulse rate is high. Tachycardia, the pulse rate is high, so it goes to tell you that something is wrong. Now, a lot of you may be thinking, oh yeah, I'm going to see the COPD. It is just 1%, but look, the patient is already on 2 liters of oxygen. It means that the care or the situation is being managed. Yes, so that rigid abdomen and tachycardia, classic sign of peritonitis. Okay, now a lot of you may be thinking the CHF. That is why I said expected. unexpected always beats expected. Is it not expected? It is expected that CHF, like when you have chronic heart failure, there is fluid overload. And when there is fluid overload, what do you see? Distended jugular vein. There are crackles. There is edema, the edema, pitting edema. There is bloatedness. There is increase in weight. They are all expected. Nothing extraordinary. But if you're telling me in this CHF there is bleeding or hemoptysis, that's cough and blood, that is unexpected. So totally abnormal for CHF. So I'm going to go for that. But in this, all these things are classic manifestation of CHF, nothing abnormal. Okay? Now, number 6 is delegation. Which assignment is appropriate for LPN? Is it A, post-op hip replacement, day 1, needing neurovascular checks? B, newly diagnosed diabetic requiring discharge teaching? C, 2-hour post-op guard patient? Or D, stable hypertensive patients needing oral meds? Thank you. You are so right. The word there, stable, actually gives it. As long as it's stable, please go ahead. Okay. Then let's go to safety question. Which action reduces fall risk in hospitalized elderly patients? Number 1. Now they say which action reduces. There are other actions that will reduce, but which one is the best? Okay, that's what they're trying to ask. Which option is the best? Number 1, raise all 4 side rails. Does it reduce the fall? Apply restraints for safety. Keep bed in the lowest position and call light within reach. And I encourage patients to stay in bed. Which would you go for? Oloma says A. Martin says A. Why are you going for A? Why A? Remember, the side rails are 2. So why A? They're asking you for, and that is one of the things I say that NCLEX, they will give you very good answers. But then in between, you see that something is wrong. We have 2 side rails. So that number 4, I know that a lot of you want a trick. You may fall for that trick. It is not A. It is not 4 side rails. We have only 2 rails. You don't have one in the head, one in the leg, right? When you raise the rails of the bed, there are only 2 rails, right? That is why it's wrong. Now, number 2 says apply restraint for safety. No, that is very restrictive. Are there other options you would have gone for? No. Then, look, they say keep bed in lowest position. This reduces for and keep light within reach. I wanted you guys to think about it. These 2 are together. If it is in the lowest position, even if they roll, remember the teaching I made? Even if they roll out from the bed, the fall will not be so much, the impact will not be that a lot, right? And when you keep call right within the range, they can just, within patient's reach, they can just press it. Hey, nurse, I need. So you guys don't fall for NCLEX trick. Do you understand? Do not fall for NCLEX trick, okay? Please tell me you got it. Tell me you got it, because we're not doing this anymore. You're not falling for the trick. Tell me I got it now. Uloma, Martin, and every other person that is watching, tell me you got that explanation, because you guys went for, oh, yes, yes, now you get it. Now you get it. Good. So we can go further. If question 8, it says, which order can the nurse question? Now we're talking about the HCP, the healthcare provider has done an order. Which one are you going to question, right? Place neutropenic patient in a private room. Are you going to question that? Neutropenic patient is those people with low white blood cell, right? So they can easily get infected, like people on certain medications, like the disease modifying medications, people with HIV, organ transplants. They don't need fresh, you cannot give them fresh food, you cannot give them frozen food. A lot of people will not come near there. They need to avoid crowds. Those are neutropenic patients and neutropenic precautions you need to take. Now, which one will you question? Will you question putting them in a private room so that others will not? Screen is not visible. I can see my screen. Can everybody see their screen? Please tell me if you can see your screen. I'm going to increase it. Can everyone see their screen? Yes. Okay, let's continue. Good. So cohorts patients with MRSA wound infection with another MRSA patient. Then it says place flu patient with tuberculosis patient and negative pressure room for TB. Which one are you going to question if the HCP tells you to do that as a nurse? Let's be fast, guys. I have less than 20 minutes for us to go through these questions. And we have 26, so we have about, is it 14 left? C. Okay, 2 people answered, so you guys are right. Why did you say that? Cohort, you cannot put a flu patient, which is droplets, with, yes, you cannot put with droplets and airborne, right? So those cohorts, they don't go together. Brilliant. Now, another prioritization question, who is priority? Is it a 2-day-old patient with jaundice, a 20-year-old with asthma attack and has respiratory rate of 36 and silent chest, or one with 40 or a 40-year-old with chronic back pain and the pain assessment is 7/10, or one who is 70 years old but has stable CHF. So CHF like chronic heart failure. Millet D says B. Okay. One more person, I will go ahead. B. Martin says B. Oloma, what do you say? And you guys, you are correct. You are correct. Why did you say that? I wish I can bring you guys to, yes, the silent chest is the giveaway. Hey, something is not happening. Something is not right with this. Why silent chest? Are they alive? So by all means, we're going to look at that person because, oh my goodness, there is respiratory failure coming in. So yes, you guys are right. Uloma, are you here? So number 10 says the RN delegates ambulating a stable post-op client. I can't see my screen, just wait a minute, I have to reduce this. So The RN delegates ambulating a stable post-op patient to UAP, and the UAP reports dizziness after walking. What should the RN do? Should the RN tell the UAP to continue walking slowly, or to ask the UAP to obtain blood pressure, or to assess the patient immediately, or document the UAP's finding? What would the nurse do? You as the RN, what would you do? You have delegated and they're telling you, oh, something is wrong. What would you do? Yes, immediately go. If there is a change, it means that you need to take over the client. You tell the UAP thank you for the observation, and you go take the client. It becomes yours because there is a change from stability to instability, right? Perfect. Okay, so yes, you're right. You have to go and do your assessment. It could be that the UAP doesn't even understand. So yes, you cannot tell the patient or UAP to go and do blood pressure. No, you go and do it. Don't delegate what you can do. Go and do it. Okay, safety. Which patient should be assigned to a private room? Is it the MRSA, wound infection, influenza, TB, or all of the above? This is a tricky question, and I hope you guys don't fall for it. I believe in you, so please think critically, because this is what NCLEX does a lot. Keep it coming, keep it coming. Martin, did you say C? Option D. Okay. Option D, brilliant. Brilliant. Yes. You guys, you didn't fall for the trick. You now think the way NCLEX does. Yeah. You guys are correct. All of them, because they are all under the contact, they are all under droplet, they are all under airborne. So they should have a private room. And in NCLEX, there is sufficient facility, there is a sufficient room. So if they can be in D, by all means, put all of them in separate private rooms. Yes, brilliant. Then prioritization for question 12. Who should the nurse see first? Number one, which is A, is a post-op hysterectomy. Hysterectomy, you know, the removal of the uterus with 250 serosanguinous drainage in 4 hours. Hip replacement day 3, requesting pain meds, new onset chest pain, there is diaphoresis, and there is nausea. Is it COPD with chronic productive cough? Which one would you see first? So you're answering question 12. Uloma, did you say A? C. Option C, definitely. Yes. This is the giveaway. There is new onset. There is chest pain. Chest. There is diaphoresis, that's sweating a lot. And there is nausea. You have to run for that. You run. It's life-threatening, so you have to do that first. Now, Oloma, I don't know if you were saying post-op hysterectomy of 250 serosanguinous. Now, it is normal after the first 1 hour that it is still bloody. Within 4 hours, it can change to a mixture of the blood, mucus, and serosanguinous. So a combination. It is normal. It is expected. But if they have stayed in the ward after 24 hours, then there is bloody fluid secretion. Oh my goodness, it is a red flag. It is an alarm, and you need to do something. I ask the question, please. It is negative. Okay, wait just a minute. I'm doing a check. Where's the question? I asked the question, please. I thought TB is a negative room. It is negative pressure. There are different things. Negative pressure, so that when the patient is going out, in negative pressure, when the patient is going out, the bad air stays inside. Positive pressure, you want the bad air to go out. So yes, in TB, you're right, there is negative pressure, but we're talking about room. So private room or not private room, if you understand. Okay, all of them need a private room, but if it is negative pressure, it is for TB. You're right, but I think you're mixing them up. Negative pressure and private room. And yes, Martin, thank you for explaining more to her. Okay. Oh yes, you got it. Perfect. Thank you. I love the energy here. I love that everyone is contributing. If you want to join the WhatsApp group, we're going to be doing this for some time. You can send me an email so you can have the notes. roselomon.business gmail.com. If you want to join the WhatsApp group, you can send me an email using that. Okay, next question. For delegation, which task can the RN assign to LPN? Is it titrating the IV nitroglycerin drip, giving routine oral antihypertensive meds, discharge teaching after the GAPCH, or initial post-of-admission assessment? Which one can be safely done? Safely delegated, you as an RN, what would you give to your LPN? Good. B. Two more answers and then we'll go forward. You guys keep it coming. I wanted to end this by 10. We have 9 minutes, so keep it coming. Option B. Perfect. Let's go on. Yes, so LPN can give the word there says routine. So he's been taking the medication. He's very stable. Go ahead. Infection control. A nurse is caring for a patient with Clostridium difficile. That's contact. That's just a clue for you guys. Which action is correct? Use alcohol-based sanitizer after patient care. I talked about this when I was teaching. Wear gown and gloves for all contact. No hand hygiene if gloves are worn, and cohorts with influenza patients. So which of these is correct? The three of them are wrong. One is correct. B. You guys are right. Correct. Brilliant. Wear your gown for all patients, but always remember, standard precaution, wash your hand with soap and water. Standard precaution. Perfect. Prioritization. Let's go. 15. Which is priority? Easy patients with DKA, with glucose over 320, stroke patient with new onset of slurred speech, stable CHF with edema, and post-op day 2 with new replacement. Question 15, is it A, B, C, or D? Militza, you were right. Yes, Ankur, if I'm pronouncing your name well, you're right. Martin, I thought you left. You're here. Good. Right. Perfect. Yes. Brilliant. Uloma, yes. Perfect. The new onset is the time. It's time sensitive. It is our clue. And yes, we're going to prioritize that. Okay. Question 16. Which can the UAP do? Can they obtain vital signs on stable patients, assess bowel sounds, teach patient incentive spirometry, or monitor chest tube output? A. Obtain vital signs on stable patients. A. Perfect. You're right. So question 17. Safety. A patient on suicide watch is restless. The RN, that's the nurse, should 1. Apply restraint immediately. Ask a sitter to remain at the bedside. Give sedative without order. Close the door for privacy. What would you do? Yes. I love the fact that you guys are giving rationale even after I've left. Like, yes, a stable, vital signs is okay to do. Keep them coming because the rationale is for you. It's going to define your principle of answering the question. So it is not for me. It's good that you know why you need to, or why you said the stable, vital signs is okay. So question 17. Did you guys say number 1? Did you say A? Are you going to apply restraint immediately? Are you going to ask a sitter to remain at the bedside? Are you going to give a sedative without an order, or close the door for privacy? What would you do? Have you already answered? Yes, you guys have answered. A. You see the way I'm looking at you, I'm asking you these questions is for you to tell you that I don't believe in your answer. You cannot apply restraint immediately. Remember the teaching I was giving to you guys? Do less restrictive, less invasive. Are there, now look at the options. Are there other things you can do without putting a restraint immediately? You've not done anything, you're going to put them on restraint? Thank you. Yes, now I get it. I'm accepting that apology. You need to apologize to me for saying A. You guys, you all need to apologize to me for saying A. Because I taught you guys, you need to apologize for saying A. You cannot restrict first. It's just like you telling me I'm going to give a sedative without an order. You can't do that. Or telling me that I'm just going to close the door. Now, what NCLEX is trying to tell you is that with all the options, if there's only one thing you can do, which one would you do? Which is the safest? B. So I hope you guys got it. You see the rule behind that. Okay, let's go to prioritization. Or let me review the answer. Yeah, it says least restrictive first. Restraints made their all last resort. Maybe the person just needs someone to talk to the person, to the patient. So less restrictive. Now, question 18, prioritization. Which patient is the highest priority? Is it 80? Let's do this very fast because I really want to end this live stream. I actually named it 1 hour, but I think I'm going to change it to 2-hour live stream. So number 18 is which patient is the highest priority? Oh, good, Oloma, good. Is it a 80-year-old with pneumonia or saturation of 88, even if the patient has 6 liters of going on of oxygen? Is it 25-year-old with urinary tract infection, UTI, and fever of 101? A 50-year-old with chronic hypertension and a blood pressure of 150/90, or a 40-year-old awaiting discharge after appendectomy? You guys, I believe in you. I believe in you. So answer the question right. Uncle says option A, definitely. Okay, I'm waiting for 2 more people and then we'll go on. Okay, Martin said A. Uloma said A. Brilliant. Okay. Brilliant. You can keep the rationale coming, but I'm just going to go further. So delegation, which patient can an RN assign to LPN? Is it a new admit with GI bleed and a hemoglobin of 6.9, COPD, Patient 2-hour post-bronchoscopy, stable hypertension needing morning meds, or chest pain with diaphoresis. Which one can you assign to LPN? Yes, Anku, you're right. Olama, are you here? Olama, are you here? Okay, you're right, option C, because it's just a stable, it's just like the other question we answered, one need given or routine hypertension, routine hypertensive medication. So yes, it's routine, stable, you just morning meds by all means. But the new admit, chest pain with diaphoresis, oh my goodness, COPD, no, you as the RN, you need to take that client. So the nurse cares for 4 patients which should be seen first to prevent transmission. Okay, so there is a patient with TB walking in the hallway without mask. There is another one, the MRSA patient waiting for wound dressing. There is one with flu, a flu patient with fever of 101, and then they have HIV patient just requesting water. Who would you see first? We're talking about safety. Yes, we're talking about safety. So who would you see first? The reason why you want to see this person first is to prevent transmission so that others don't get it. Why are you retracting your comment, Uncle? And you were right. Why did you retract your comment? I think this is what the NCLEX does to you. Sometimes you see other options and you're like, oh my goodness, maybe number 1 is not right, and then you find out that it's right. So go with your gut feeling, okay? Go with your gut feeling. The first thing you said is actually right. Don't retract it. I have come to believe my first option. When I think, oh, maybe this is right, I try not to change it, and then I realize that actually the first one I would have changed to a wrong answer is actually right. So in NCLEX you face that, but don't change it. You're right. They said tuberculosis airborne. I know a lot of you are still thinking, let me help you. Airborne. And this patient should be in a private room. This patient, if he's going out, he should use the N95 mask. It should be in a negative pressure room. And this is the client walking in the hallway. Hey. Option A. Don't be walking in the hallway without mask and you have TB. No. They said the MRSA is waiting. So he's in his room just waiting for wound dressing. You don't need to do anything. Just dress up well and go and do the wound dressing. So him waiting is not a threat because they did not specify he's waiting in the hallway, right? Flu patient with fever, that is expected. It is symptomatic. If you have flu, you have high fever, go give him antipyretic, give him paracetamol. HIV, he's not giving you the medication, he's not going to give you the HIV because you're going to give him water. So you don't really have to think about the guy. Okay, so 21 says, which action requires intervention? UAP, assisting patient with ambulation using Gates belt. Patient with NG tube tied down to gown, bed locked and in lowest position. IV pump plugged into red emergency outlet. You guys, we have keep the questions coming. B, okay? Is Martin Oloma Millet, if I'm pronouncing your name, are you guys here? Miletza, are you here? Okay, because of time, I'll just go forward. And yes, you're right. It is not supposed to be tied down. It is supposed to be secured. So the tied down is a problem. Now the IV plugged into red emergency outlet. It's like it can be plugged, but if we need to access it, you need to put the emergency outlet. It is normal, right? Bed locked and in lowest position, that's very normal. Prevention of falls. UAE assisting, no, but NG tube, nasogastric tube, it is not supposed to be going down. Tying, don't tie it. It has to be, yes, pinned, okay? So number 22 is prioritization. Who is priority? Is it a post-op with urine output of 15 milliliters per hour, or stroke patients 24 hours post-admission with slurred speech, or CHF patient with 2+ pitting edema, and a diabetic with a blood sugar of 180 milligrams. Let's be fast, guys. It's way past my bedtime. Yeah, correct answer is Uloma, you here? Uncle, yeah, I got it. I got your answer. I'm just waiting for 2 other people to comment and then we can go further, because maybe they're still thinking. What do you guys think? And Uncle, since they're still taking the time, why did you say it's A? What's your rationale? A. Yes. What's the rationale? Yeah. So in post-op, it should be about 30 in normal, and post-op it should be 30 milliliters per hour. Now we're seeing 15, like half of it. We know that the kidney is in shock and there is a problem. So delegation, which task is appropriate for UAP? Sanctioning the track. Yeah, I did, Martin. Yeah, so it's definitely a stroke. Yes, that is quite confusing. The stroke patient 24, that's a day after admission with slurred pitch. Stroke, it is actually, the slurred pitch is part of the classic manifestation of stroke, right? But they did not say this stroke is new onset. Is new onset. They didn't say that. But why we went for option A is that even if they did not say new onset, they say with. That with means that it is the current situation, that it is 15 milliliters per hour, and it should be 30. It shouldn't be 15, it should be 30 per hour. So 15 means the kidney is packing up. That is dehydration. Okay. Delegation. Which task is appropriate for UAP? Is it suctioning of the tract, ambulating stable patients 1 day post-op, administering enema to unstable patients, or reinforcing diet teaching? Yes, Ulama, you're right. Ambulating stable clients. That can be done. Okay. So another safety question, which action is correct during blood transfusion? Is it using 22 IV line for 22G, that's the gauge, with dextrose 5 in water, or checking the patient ID and blood with another RN, or running the blood through the same line as TPN, or leaving the blood hanging for 6 hours if not finished? Martin says B. Ulama, what do you say? Tenzin says B. Martin says B. Okay. Ulama, what do you say? Yes, safety. It is, there are kind of standard precautions you need to do. Now, I think a lot of you, maybe some of you have not gone through the procedure of blood transfusion. In blood transfusion, you cannot, never use any medication, any IV that is not normal saline. So sodium chloride and the 0.9. Okay? You cannot use dextrose in water. We're talking about blood. So you cannot, when you're preparing the IV line, what you use to prepare the line is normal saline, because it is isotonic. So you cannot use hypotonic, you cannot use hypertonic, right? You must check the patient ID, you must check compatibility, and you must do all those things, not alone. You have to do it with another RN. And you cannot run blood through the same line with the total parenteral nutrition. You can never do that. One thing about blood is that blood transfusion and TPN is that they are on their own. They love their privacy. So you can never mix a line. You cannot use the same line for medication, give medication in a TPN line or with a blood. They stand on their own. And for blood, you can never give a blood more than 4 hours. And now we're talking about the red blood cell. Red blood cell, you have to give it within 4 hours. But if you're talking about the platelets, if you're talking about the plasma, they are actually giving within 2 hours. It is even the red blood cell that you can give within 4 hours. And once you get the blood and you've not given it within 30 minutes, you have to send it back to the blood bank, because it's not supposed to stay in the room temperature without being infused. So I hope you guys, I think we have covered some kind of safety precautions when it comes to blood transfusion with this answer. Okay, so number 5 is, which is priority? A child with asthma and wheezing, but the oxygen saturation is 94, or a child with epiglottis, drooling, and has stridor, or a patient with sickle cell pain and is 9/10 in the pain rating, or a child with gastroenteritis and has mild hydration. So which? Thanks, ma'am. I'm from India, New Delhi. I'm a BSc nursing student in the final year. Wow, congratulations and success in your endeavor, uncle. Welcome to the profession, and I think you're doing well. So you are gonna ace the NCLEX. Yes, Martin, you're right. You guys saw it. Option B. Option B. It's shouting, help me, because we're talking about airway, epiglottis. We're talking because glottis, that's airway. So it's drooling. It cannot even breathe. So the child is keeping the saliva and all that. We need to go for that client first. The one with wheezing and the oxygen saturation is 94, well expected. The one with sickle cell pain is excruciating. It is expected. Classic manifestation of sickle cell is that the pain is painful, really excruciatingly painful. Gastroenteritis with mild dehydration, well, that's normal. Yes, go ahead, Martina, ask a question. And that will be the end of, oh yeah, I have one more question and that will be the end. This, oh Loma, are you here? Oh yes, you're here. I didn't know. Yes, you're here. Good. Okay. The last question, I saw this and I'm like, I had done 25 questions, but I was like, I need to show you guys this because I had left in my WhatsApp group about NCLEX review that you guys should go through the lab or the lab values you need to know before doing the NCLEX. So I wanted to know if any of you actually went through. So I was like, I'm gonna put this number 26. It says, which lab requires immediate action? Is it the potassium of 3.2 with no ECG, ECG change? Is it hemoglobin that is 8.9 but asymptomatic? Is it a platelet with 40,000 but oozing gums? Or sodium with 151 with test? Like, which one? Option C. Okay. Let's say option C. One says hemorrhage variants. Ulama, what do you say? Ulama, once you answer, we're gonna end this. So this is the first this is the first NCLEX review class I'm doing for the month of September. I'm going to be doing this NCLEX review and it is totally free. But I think from the month of November, it's going to be more September, October, next month, October, is going to be more intensive. Ulama, I'm waiting for your answer why I'm saying this. It's going to be more intensive and it's going to be paid. But if you want to join the class, if you want to join the group, you can send me an email using that. And there I can kind of share daily reminder of what you need to do. We talk and encourage ourselves. But what else? My background, I am a nurse, so I'm US RN, I'm Canadian RN now, all thanks to God. And I'm licensed to practice in Nigeria, that's my home country, and in Finland. So I've done my basic, the RN, I did the bachelor's and did the master's. I did my NCLEX in 2023 for the first time and I passed again, all thanks to God. So this is me saying that if I can do it with my full-time study, I did not stop working. I was doing my full-time work with my family and I was able to pass. So I was like, I know some strategies with the help of God. I can help others to do this. So this is kind of the first part for this whole month. We're going to go through this every Wednesday with 8 p.m. we're going to do the review. I'm going to do the teaching, the contents, because content is critical. If you don't know your content, you will not know how to answer the question. And after that, we're going to do an answer like we have done today. So the next time we're going to have this class will be next Wednesday, 8 p.m. same time. Now, one thing I have to say is that God is able to help you. One of the things I did when I was preparing with the nervousness and uncertainties about if I was going to pass, the Bible says in Proverbs 18:21 that death and life are in the power of the tongue, and those who love it will eat the fruit of it. So what I do is whenever I'm writing, whenever I'm studying, I have my notes. I always write, I, Roselyn, I have passed my NCLEX in my first attempt. I kept speaking word of faith and I kept reading, and that was what happened. I created my reality. I prayed for it, and most importantly, I put in the work. So what I was doing is about 1.5 months before my NCLEX, I was doing every day 85 question on UWord. I have UWord, I'm not in any partnership with them, but if you really want to ace the NCLEX, after you've done the content, go on UWord and practice. You need to practice because the UWord, they've actually simulated it, the difficulty and all those things is in alignment to the actual NCLEX. And I think that NCLEX, the UWord, is more difficult than the actual NCLEX. So if you're able to pass, I think you're going to ace it. I believe in you. If I have done it, I see myself as one to tell you that what you're praying for is attainable. If I have done it, if I'm able to do it, I don't have two heads. I just put in the work and believed in God, and God came through for me. That same God is going to help you. So it is attainable. So believe in yourself, put in the work, and I'll be here cheering you on and doing the best I can. Okay, thank you all, and we're going to see in the next video. You can go to my channel. You'll see some of the old videos when I talked about if you want to hear about my NCLEX journey, you can see the playlist on the nursing. Watch it. I think I've also done another review, so use that. Good morning, mom. Good morning. Hey, Jeannie, you're coming when we're leaving. You can actually watch the replay. But guys, this is way past my bedtime. I'm going to go to sleep. But see you next Wednesday for another review class. If you're just joining, you can watch the replay. And you guys, thank you. If you want to join the NCLEX class, send me an email. I'm going to join, add you to the group, and we're just going to support ourselves. Okay, thank you, and I'm going to pray for you guys, for especially the people that asked for Martin. I'm going to remember you in my prayer, and I know you're going to ace it. Okay, see you next Wednesday, 8 p.m. Canadian Toronto time. And yes, thank you, Ulama, for being here. Ulama is actually the first student, the one that the reason why I'm doing this here. At some point I was like, I wasn't going to do it, but I believe that Ulama, you're going to get it, and I'm so proud of you. Okay, bye for now.